come? Oh, okay. Oh, this. Yeah. Okay, so my name is Amish Dave. I'm going to introduce myself, but before I do, I'm going to give you some housekeeping items. So first, we are broadcasting. Please use microphones to ask me questions at the end. We are broadcasting live to a worldwide audience via Vimeo and YouTube. The recording is always available for viewing, and please like, comment, subscribe, and share our YouTube channel. For our viewers, if you'd like to ask a question or submit a question, please text DeBakey to 37607. Our upcoming training activities are the Heart of a Woman Conference on February 7th and the Houston Heart Failure Summit on February 15th and the Robotic Surgery Summit on March 11th. So I will introduce myself. I'm Amish Dave. I'm one of the electrophysiologists at Houston Methodist Hospital. I run the pacemaker clinic and I help with the training program. So I've been practicing over here for 15 years. I'm the main lead extractor at this hospital now, and I have come from UCLA for most of my training. So we're going to talk about lead management at Houston Methodist. Basically what goes in sometimes really has to come out, and we'll talk about how we take it out and who needs to have it out and what are some of the newer things in this field. So my learning objectives for everyone are really threefold. I would like everyone to be a little familiar with the patients who really should be getting an extraction or understand about evacuation or suction evacuation of sizable vegetations from the heart and know that we can do that, and some patients really should get that done. Second, there is a mortality impact, a significant mortality impact with delays in extraction in the setting of lead endocarditis. And early referral and early extraction really has a significant mortality benefit. And the third is we're going to talk about the impact of jailing leads when you put a valve in the tricuspid position or in the SVC position, and the impact that might have in the future of the patient and the future of the lead. So the background, by way of background, basically we have lots of patients with lots of leads. We've been putting stuff in for decades. Right now we put in about 400,000 implants per year of pacemakers, defibrillators, biventricular devices. And worldwide it's about 3 times that. The population of Olmsted County includes about 1.5% of those patients have devices. If that was true in Harris County, we'd have something like 60,000 or more implanted devices here. Aging is driving an increase in the number of implants. We have been, we've had transvenous pacemaker leads widely available since the 1960s, for defibrillator leads since the 1990s. So routinely nowadays in our clinics and in our consults, we see patients who have had leads in them for decades. And the lead failure rates are really something that's a number per year. In general, the worst of the newest leads are better than the best of the older leads, but it can be 1 to 8% within about 5 years of implant. There are some recalled leads that are still in circulation in patients. These are the Medtronic Fidelis and St. Jude or Abbott Reata leads. They have very high failure rates. There are also patients who have lots of leads and hardware that have been abandoned in them. When older leads were put in and they failed, then the easiest decision was always not to take it out, but just to put another one next to it. So this is a patient of mine who has had a pacemaker for half a century. She's now almost 90, and the older leads were very prone to failure, and every time something happened, they kept adding, and so now her x-ray looks more like a bird's nest than a human chest. The complications when you have so much hardware in are, that of course the risk of infection is somewhat proportional to the amount of hardware that's in you, and that goes up. Thrombosis, valvular regurgitation of the tricuspid, and also even SVC syndrome. So when do we want to take out stuff? Well, basically, the indications fall under either infection or lead failure or lead management, which we'll describe later. when we want to extract the lead or take them out of a patient, the reason this isn't so trivial is that the body creates these very fibrotic binding sites that bind the lead to the vasculature and to where the leads are in contact with each other. And this stuff gets, it's very tough tissue, and eventually, especially in dialysis patients, it gets even very calcified and bonified. So when we pull out the leads, it usually requires quite a bit of force and a significant amount of traction. Speaking of traction, in the olden days, the technique of Buck's traction was applied to removing leads. Here you see a diagram where a surgeon would basically apply with a pulley some weights to apply the force to the leads, and they would just progressively increase the amount of weights on the sutures. And the quote says, "The sound of the weights crashing to the floor signaled successful lead removal." Thankfully, that we have newer techniques now, but the traction that we're applying on these leads applies significant force to the mediastinum and the SVC. Here you see the SVC being pulled by the traction that's being applied to the leads. It's not hard to imagine that we can tear the SVC wall, which is the number one concerning risk from this procedure. So some of the newer tools we use are sheaths like this one that have an excimer laser that shines out of the tip, and this can easily cut through biological tissue. In this case, it's going through an orange peel like butter. It goes through a hollow tube, and the lead goes inside that sheath. And when we pull on the lead, that helps keep this sheath and laser intravascular, and then we can cut through those fibrotic binding sites with the laser as we advance it forward. So the laser is not the only tool. We have other types of sheaths that have mechanical cutting devices. In these cases, there are two of these that have a diamond tip cutting blade that can turn in circles as we pull a trigger mechanism, and that can mechanically cut through binding sites, especially useful when there's calcified binding sites that the laser doesn't work that well in. In all these cases, though, it's very important that we apply traction to the lead to keep the cutting tools or the lasing tools intravascular. And the importance of that can't be overstated, because without sufficient traction, then we can very easily lase or cut through the vessel wall. This is actually intriguing. This is a video-assisted thoracoscopy during lead extraction at Mayo Clinic and certain other centers. This is done for the select cases, basically through a single port in the right rib cage. With the right lung deflated, they can visualize the laser sheath, in this case, trying to remove the right atrial lead. This is the right atrium. And in a second, the right atrial lead is going to pull into the sheath, and right there, the lead and sheath get pulled back. So by being able to visually see the dimpling of the right atrial wall, you can hopefully titrate the forces that are being used, and same thing for the SVC wall. There's a very useful adjunctive technique, which is to go from the groin, from the femoral vessels, and we can snare the leads with a tool like this one. And when we grab the lead in the middle, we can sometimes just completely remove the leads from the femoral veins through a fairly sizable sheath. And sometimes, even if we decide that we are going to still try to remove it with a laser from above, by being able to apply some traction from below and from above, that allows us to create a better rail with the lead, and again, more effectively keep the laser and the cutting sheaths intravascular. And in addition to tearing of the SVC or innominate veins or things like that, there are some other complications. The common one is not that common one, but a risk is damaging the tricuspid valve, and that's usually related to just where and how the lead was implanted in the first place. In this case, a lead was actually screwed into the papillary muscle of one of the tricuspid leaflets, and actually went through the tricuspid valve leaflet. And fortunately, they recognized this and did not try to lase through it, and this patient obviously had surgery. So we know that there's some risk to this procedure, and there are ways of knowing or estimating the risk before the procedure. There are scoring systems that you see over here that have been developed and validated. But basically, in common for most of these is that, the older the lead, the harder it is to remove. When there's multiple leads, of course, that gets harder. If there's an SVC coil, defibrillator leads will have a good amount of metal sometimes in the SVC portion of the lead. That gets very fibrosed and of course, adherent to the SVC wall. That increases the risk. Chronic kidney disease really increases the fibrosis and the calcification of these bindings and increases the risk. Passive leads. So an example of one of these scoring systems is this one, and basically if you sum up the dwell times of the leads and look at the age and other aspects of the patient, you can assign a patient to a category where the lowest risk patients have a very low risk, basically less than 0.5% risk of a complication. But the highest risk patients have 50 times higher risk of complication. And being able to sort of triage the patients obviously is helpful ahead of time in explaining the risk of the procedure to the patient and also deciding, what are the approaches we want to take. So speaking of the indications for the procedure, we're going to first talk about the infectious reasons to remove a lead. Infection rates are rising. As more and more patients have implanted hardware, there are more and more infections. But also, you can see in this 16-year series that starting around the mid-2000s, there was really a spike in the infection rates. And that's because the patients who started getting transvenous defibrillator leads in the 1990s and 2000s started getting battery depletions and battery replacement surgeries. And those patients are generally sicker. They have other comorbidities. They have heart failure and coronary disease and diabetes, et cetera. And that all increases the risk of infection. There's been wide agreement that conservative therapy, basically trying to treat these infections with antibiotics, is not going to work. It has basically a nearly 100% failure rate and a one-year mortality in the literature of between 30 to 38%. This is an example from the literature in the Journal of Thoracic Cardiovascular Surgery from 1985. The conservative approach failed in all but one of the 32 patients. In this paper, no attempts should be made to save an infected system from removal because it endangers the patient's life, prolongs hospitalization, increases costs, and most likely will fail. Surgeons are never subtle. The paper over here in 2003 in chest, conservative treatment without explant of all hardware failed in all patients, and surgical treatment during antibiotic therapy was effective in eradication of infection, but was associated with a 12.5% mortality. And the only patient characteristic associated with treatment failure or death was the absence of surgical removal of all hardware. So there is consensus that basically trying to treat this conservatively generally will fail. But more recently, it's really become clear that when do we extract is a very important concept, and the timing really matters. So in this particular study from 2023 in JAMA Cardiology, they did a review of the Medicare database, and they identified 11,300 patients that they studied. These are patients who had a cardiac implantable electronic device, a pacemaker, defibrillator, et cetera, with an infection. And some of these were pocket infections, some of them were endocarditis. And they just tried to see what would happen to these patients and when. And what they found was that only a portion of them, 2,000 of them roughly, had extraction within 30 days of the diagnosis. And of those, about three-quarters had extraction within 1 week, and 1/4 had extraction more than 1 week but less than 1 month. And when they compared those groups of patients and looked at the long-term outcome of these patients, the one-year mortality, all cause, it was very clear that the sooner you extract, the patients who got extracted within 1 week of the diagnosis had a significantly improved mortality rate compared to those who had delayed extraction. And, the idea that only a subset of these patients are getting extraction is really important. In this case, endocarditis, not pocket infection, but only about 17% of these patients with endocarditis were getting an extraction at 1 year from the diagnosis, which is shocking, but, it's fairly true that when I get patients, sometimes I see patients have been through rounds and rounds and rounds of antibiotics, and then they fail, and then they come back and with the sepsis, and you know, it is something that most EPs have seen. So there are two basic categories of infection. There are superficial pocket infections, and then there's endocarditis. And they're really, there are different populations. A pocket infection can be very obvious in cases where you have pus or in cases where you can actually see the hardware. But sometimes, like on the left over here, it can be fairly subtle, and you would sometimes have difficulty distinguishing this from a seroma. Obviously, clinical grounds like a warm pocket or tenderness or things like that are helpful. But sometimes the infection is a little bit less aggressive, and it can be a little bit tricky to tell. So there are tests that are helpful. Things like an ultrasound or a CAT scan are not particularly useful in distinguishing a seroma or a hematoma from an infection. But an FDG PET is actually very useful in this situation. It has extremely high sensitivity and specificity for identifying a pocket infection when there's doubt. In this situation, there's a case of lead endocarditis with a very huge vegetation over here by the tricuspid valve on a lead. This is not subtle, and obviously, if you see this, there's no doubt in the diagnosis. This, vegetation, and sometimes we see things like this that are this size, is of great concern. If this embolizes, that's going to cause, a very high risk of hemodynamic collapse. But it's not always that subtle. I mean, it's not always that obvious, and sometimes it can be subtle. We remember Duke's criteria, the modified Duke's criteria. This has been, time-honored and still extremely useful. And these criteria, if you remember, have two major criteria, 5 minor criteria, and depending on how many of these criteria the clinical scenario gives you, you can make a definitive diagnosis of endocarditis, or you can make a diagnosis of possible endocarditis or rejected endocarditis. And if you look at the test characteristics of the Duke's criteria, it's very useful. It's about 80% sensitivity and specificity for either a definite or a possible endocarditis result. TTE, transthoracic echo, when you actually see a vegetation, that's several centimeters big, is obviously very specific, but the sensitivity is very poor. TEE is actually fairly disappointing when you look at it as a test characteristic. It's very often the case that you'll see some lead-associated echo densities on TTE, TEE, or ICE that are really not infectious, and it can be sometimes tricky. But when you see something very obvious, then it becomes very clear. But FDG PET is emerging as a really useful test in these cases. In lead endocarditis, it has a test characteristic, about 80% sensitivity and specificity for confirming or rejecting infection. In this case, you can see the images on the left over here show uptake or tracer intensity at the pocket, which is a pocket infection, the metabolic activity from the infection caused by the infection over there. And on the right, you can see the intensities in the heart associated with the leads. And so this type of a test is very useful. In this study, published fairly recently, they looked at patients, in this case about 70 patients who had a not definite but a possible diagnosis of endocarditis based on clinical grounds on the modified Duke criteria. And what they found was that 63 of these 70 patients were able to be reclassified. So 26% were, through the FDG PET, reclassified to definite infection, definite endocarditis, and this is all lead endocarditis, not pocket infections. And 64% of them were rejected as having endocarditis. So in a Bayesian sense, this is a really useful test. Once you have identified a patient as having a pocket infection or lead endocarditis, there is really broad agreement about the management. In the 2017 Heart Rhythm Society guidelines, really removal of the entire system has a class 1 indication, pretty much throughout. In the recently published roughly one year ago, scientific statement by the American Heart Association, they basically reiterated the 2010 guidelines, which basically say, remove everything when you have definite infection. Same thing in the European Society of Cardiology endocarditis guidelines from 2015. removal of everything is recommended in all cases of proven infection. And also, most of these guidelines also say if you suspect infection, if you've ruled out other sources, removal of the hardware, is very much indicated. So why are these patients not all getting referred for immediate extraction? And it's really because there's concern for the risks of extraction. There's also a lack of access to experienced extraction centers. They're not people who are familiar with extraction in every hospital in the country, certainly. But in terms of the perceived risk of the procedure, definitely there are risks. But when you look at the published studies and the outcomes of the extraction in the hands of people who are fairly experienced at lead extraction, the success rates are actually fairly high. In this case, in this analysis of many papers over 2 decades, the success rates for extraction was about 95% or higher in pretty much all of these. The major complication rate was, less than 4% in again, experienced hands. And the mortality of the procedure was, around 0 to 1% in each of these papers. Obviously, there's a publishing bias over here where nobody who has lots of mortality will publish their results. But, this is saying that basically we can do a safe job and a successful job in many cases if we're experienced at it. And when you look at those numbers, the complication rates of lead extraction, which pretty much everyone, rightly so, is concerned about, they compare fairly favorably to the complication rates and mortality rates for other procedures that electrophysiologists do. In this case, VT ablation and AFib ablation and left atrial appendage occlusion are being shown. So, I basically sort of have expounded on how important it is to extract whenever there's an infection, but there was a recent development that came out in 2023 in this paper by this group from Israel that really could be game-changing in some situations of pocket infection. So in this study, what they did was they decided that they would try to not extract in cases of a pocket infection and instead would try to infuse high doses of antibiotics locally into the tissue and to see and compare these patients to matched. It was a case control study, so similar patients who got an extraction. Now, this was applied to 65 patients who got the antibiotic infusion, continuous in situ antibiotics, were compared to 81 patients who got an extraction. And the extraction patients were in another hospital, and the antibiotics were at one hospital. I should say that they had very few patients with staph, which matters because staph infections, coag neg staph, Staph aureus, are generally more virulent, harder to treat. So this may not really apply to staph infections, but they basically found, after a 3-year median follow-up, that the extraction was better. So the extraction success rates were 96% versus 85%, and that was statistically significant. But of course, there were also many more complications in the extraction group, whereas infusing antibiotics was generally, safe. And the 1-year mortality was similar between these groups. So the way it worked is, if you identified a patient who had an obvious indefinite infection, they would then open the pocket, debride it, remove all the necrotic and infected material, create a new tissue plane, usually submuscular, subpectoral, clean out the device, try to clean out the leads, put the device in the new pocket along with the tip of a central line. The central line catheter would go into the pocket with the new device, and then they would measure antibiotic concentrations in the serum every day for 10 days, and they would infuse the antibiotics until the serum concentrations were therapeutic. What that meant was that in the pocket, the concentrations of the antibiotics were many orders of magnitude the minimum inhibitory concentration, such a high concentration that in fact it could penetrate the biofilms and eradicate infection. So, and this is the appearance of the incision and the erosion of the skin after healing. So this can work, and it may be a reasonable option for many people who are high risk for extraction. What we don't know is, if we go in a few years later to remove that generator and replace it, is that going to reawaken any colonized bacteria over there and then lead to extraction? So there is still some doubt, and I still think this is provocative and very useful in certain situations, but if the leads are relatively low risk to extract, I think extraction should still be the main approach. And that's still, this is not in the guidelines. There's another very important adjunctive tool that we use for endocarditis. So many times, as in the case I'd shown you, there are fairly sizable vegetations attached to leads. These can be several centimeters big. And you know, historically, when the vegetations are 2.5 centimeters approximately or bigger, there's, you know, that's usually an indication for surgical extraction and surgical removal of the vegetation. But, you know, these patients are septic and they're very high risk for surgery. So an alternative approach is to evacuate the vegetation through a percutaneous approach. So this is one approach that I've been using for about 5 years here. This is the AngioVac catheter. It's basically got a funnel, and it's able to be deflected and steered. And it goes and connects to a cardiopulmonary bypass machine. And so we basically have veno-venous bypass, and we can apply 3.5 liters per minute of flow to create a suction. And that can literally suck out the vegetations into a filter on the bypass machine. So this is not the kind of thing that has been tested in randomized clinical trials, nor probably will it ever be. In general, if we have a patient with large vegetations, it's hard to randomize those patients to surgery versus this when we know that this is you know, fairly safe. How do we know it's fairly safe? Well, in the study over here, this is a retrospective study through multiple centers using 101 patients. What they found was the success rate was about 94% for complete extraction of the vegetations, 5% for at least partial removal of the vegetations. There were 3 complications, but you know, one of these was a iliac vein tear that was repaired, and the patient did fine. Another one, when you first turn on the pump, there's a lot of blood that comes out of the blood vessels, and that can pose an immediate, temporary, transient hemodynamic stress to the patient, and that patient required a little resuscitation, but a few minutes later they were fine and they completed the extraction successfully. And then one patient was a Hail Mary type of procedure. It was in fluoride septic shock on multiple high-dose pressors and basically died of the septic shock during the procedure, but they did not adjudicate this as a complication of the actual suction itself. How does it work? Well, in this case, you can see the funnel is coming up from the femoral approach. It can also be brought down from above from the internal jugular vein, which sometimes makes it a little bit easier to approach the tricuspid valve. And it's steerable, and we can see it's really making contact with the lead, which is where the vegetation is attached. And the suction will make the vegetation stick to the funnel, and then it basically breaks off in pieces into the filter, which breaks it apart, and you're left with many pieces like this, and this is fairly significant bulk of material that is not embolizing to the pulmonary vasculature. So this is a modification of that device where it's still the same funnel and same device, but now there's a handheld tool that applies suction using your hand. It's called the AlphaVac. And this, because you don't need the cardiopulmonary bypass, there's only one venous cannula, is something that we can do actually in the cath lab. This is a case that I did in the cath lab. And again, a very bulky vegetation that would have had significant consequence if it embolized. From the time we got access to removal of the vegetation was less than 15 minutes. And the blood loss, with this device, you don't return any of the blood. So if you go hog wild sucking into the machine, there's some blood loss. But the blood loss was only about 50 or 100 cc's in this case. So who should get this? It's really for people with large vegetations, if it's over 2 centimeters. Also patients who have a smaller vegetation but who have a risk of a shunt, who have a ASD or VSD or PFO, where there was a risk of left-sided embolization. That would be a very reasonable patient to try to aspirate the vegetations, I think. Now we'll talk a little bit about lead failure. Basically, this is another indication. There are many types of failures. They basically fall into an insulation problem of the lead or a fracture of the conductor. And sometimes this is very obvious. The St. Jude or Abbott Riata lead has this recall, a Class 1 FDA recall, because the conductors can actually come out of the outer insulation, and that can lead to noise and over sensing of noise, leading to inappropriate shocks and actually VT storm. So that happens to leads. This particular lead, it's not recommended to remove it prophylactically, but we follow it, and when we identify a problem with it, generally we either have to abandon it and put a new lead next to it, or we have to remove it. And in this case, you can see a very obvious conductor fracture of a pacemaker lead. Sometimes the fractures are a little bit more subtle. In this case, you really have to look very closely with in this case, microscope. But early fracture, even like this, can cause problems like oversensing. There's oversensing of noise that leads patients to start getting inappropriate shocks when the defibrillator that this lead is connected to interprets this noise as ventricular fibrillation. And so this is another very common reason for extraction. And then lead management basically refers to thinking about the lifetime of the patient and basically trying to avoid this from happening to your patients. So if we look at a real-world example, this is a patient who had congenital heart disease, DTGA, had become pacemaker dependent a long time ago. And this is done in a relatively modern era where in centers where they actually did have the ability to extract, but they sort of decided not to. And of course, eventually this patient developed Moraxella bacteremia, and FDG PET identified the infection on the leads sort of near the SVC baffle. And this is a nightmare to extract. A lot of these leads were cut. Some of them actually wound up being cut so proximal that they actually went into the vessel, into the bloodstream, and then the blood flow through the subclavian forced the lead to prolapse forward through the SVC baffle, through the mitral valve, up through the pulmonic valve. And this lead is actually in the main pulmonary artery. That's bad. So we tried to extract all this stuff with reasonable success, we thought. We wound up extracting some of the stuff from the femoral approach, some from above. And in the end, we were left with this particular lead I could not snare from below. It was going through all those baffles, and everything it made it impossible to snare. And a few broken off fragments of leads that were probably just embedded in muscle and probably low risk. But unfortunately, the infection persisted, and this required Dr. Corti to save him. And the patient's doing great now, and got a epicardial pacemaker. Sometimes lead management involves dealing with complete occlusions of the SVC or the innominate vein, and if we need to add a lead, what do we do? Sometimes we have to extract the lead in order to regain access to add a new transvenous lead. But if we can avoid doing that by revascularizing, in this case the SVC, here we did balloon angioplasty of the SVC, allowing us to add more leads later to this patient. And this allows us to spare the patient from the risk of an extraction. I want to, sort of say a little bit about this procedure. This is something that's really now increasing in prevalence. Just this week, I have 2 of my patients who are getting this. Actually, this morning, one of them is getting this procedure. There are new therapies for tricuspid regurgitation. These are really important therapies. These patients have had limited options. Many of the patients with severe TR are not the best surgical candidates, and there have been tricuspid clipping procedures and transcatheter tricuspid valve procedures, and nowadays we have in investigational use a SVC and IVC valve placement procedure, the trick valve. What these procedures, though, oftentimes involve is also, many of these patients also have hardware. They have transvenous pacemaker leads or defibrillator leads. In this case, you see a defibrillator lead that was jailed off and is abutting the tricuspid annulus by a transcatheter tricuspid valve. And this raises some concerns among extractors. When this is done, that is a lead that we will never be able to extract percutaneously. When this needs to be extracted, it's going to be an open surgery. That's not going to. I don't think any extractor is ever going to try this with a laser or anything like that. So it's consequential, but also there are some other risks. So in this paper about four and a half years ago, the question of what happens to these leads and is it really safe to put a transcatheter tricuspid valve when there's a transvenous lead was asked. And these authors basically looked at their registry of 329 patients. They identified 28 patients who got a transcatheter valve where they did not remove the lead, they actually just jailed the lead against the tricuspid valve. And they saw that 3 of those patients had a complication to the lead. One of them in the procedure, they dislodged the lead. Okay, so that can be fixed. But 2 of them within actually 15 months had fractures of that RV lead. That's a fairly significant failure rate. But their conclusion was that, look, the procedure outcome was fine. The tricuspid valve did fine after the procedure, and actually the mortality was the same in all those patients, whether they had an entrapped lead was very similar to the mortality when they didn't have a lead or didn't entrap it. And since the tricuspid valve was working fine afterwards, they said, this is all great. They raised some concerns, and they didn't say this is great, but they did say that this is feasible. The editorial in the same issue raised some concerns, though, about all this, and really a failure rate of 2 out of 28, is about 7% failure rate in 15 months is much higher than the failure rate of the most horrible recalled lead that we have. I mean, it's a significant concern, and really this is really the important point. If a patient is pacemaker dependent on that lead, a failure rate of 7% in 15 months is really not acceptable. That failure will lead to death at a fairly high rate. So the fact that the patients in that particular 28 patient group did not die is maybe not totally reassuring. But also in this paper by Callahan and Wilkoff, in a letter to the editors for that regarding that study, they raised the concern that if these patients get an infection, this is going to be an open surgery, and these patients are by definition a high risk for surgery. So infection rates are published at around 1.9 per 1,000 patient years. So if we start doing this procedure for enough patients, this is really going to happen. And actually, of those 28 patients, one of them did develop an infection. It was after the study was published, but that this is not an academic point. This will happen. So, when patients have tricuspid valve problems or when we've extracted leads, there are new developments, not all that new. These now have been out for a while. Basically, leadless pacemakers, I think, are going to become more and more prominent, and these are great options once we've extracted an infected device. These devices are small, and they're, for fortunate reasons, they're very resistant to getting infected. We can put these in relatively soon after removing a vegetation and removing a right ventricular infected lead, and they basically, the patients do fine and they don't continue to have endocarditis. They're leadless, and so we probably don't have to worry about tricuspid valve problems or things like that. There are devices from 2 different companies. On the left, we have one from Medtronic. On the right, a system from Abbott. They can maintain AV synchrony to an extent. In this case, the lead can sense the atrial contraction and synchronize RV pacing to that. On the right, you can actually put a leadless pacemaker in the right atrium and one in the right ventricle, and they can talk to each other and synchronize the contraction that way. So this is going to be more and more prevalent. Maybe not my generation, maybe not the generation of the EPs that we're training right now, but soon after that, I think they'll look at transvenous leads and say, what the heck are we doing? This is like trepanation. But for the next 40, 50 years, we're stuck with patients with leads. Defibrillators are also available without leads in the vasculature. This is a subcutaneous ICD. This has been around for over a decade and really is in high use. This lead there is a lead, but it's under the skin subcutaneously outside the rib cage. And so you know, not something that would be very risky to extract. And in this case, this is a newer device by Medtronic, and this is a lead that's placed under the sternum in the anterior mediastinum, and again, not in the vasculature, and you know, fairly resistant to endocarditis. So, you know, with that said, I'm almost done. We're just, you know, going to stress that lead extraction, lead management is really a multidisciplinary field. Obviously, every lead extraction case requires a CT surgeon basically on standby right there. This is a procedure that, if you did have a complication, requires a surgeon, you know, to be immediately available. And so we partner with surgeons very closely with this. Obviously, the infectious diseases services is very important in this. The valves team is very important. Imaging, as I've shown, is invaluable for our patients. So with that, I'm going to conclude the talk. Thank you. And I'll open to questions.
So Amish, we have the dilemma. We have the dilemma quite often of our colleagues ask us to assess a patient that has tricuspid valve regurgitation that is severe, and there is a lead in there. And depending on who you ask, the imaging people may say, yes, the lead is there and it's causing a TR or not. And we're faced with the dilemma of we don't really have a firm diagnosis of lead-induced TR, and our only potential therapy is to take it out. Where do you see this getting better, or are we stuck in this?
No, it's definitely a real problem. This happens very often, and you know, I think most extractors feel that when there's been tricuspid regurgitation for many years, for some arbitrary definition of many years, even if the lead was the cause of the tricuspid regurgitation, removing the lead will not fix the tricuspid valve. But if it's relatively acute, I have seen a patient have improvement in the tricuspid regurgitation when the lead is relatively recent. When it's relatively recently placed, it's also easier to remove. And so for certain of these patients, it does make sense to extract. But I think you really have to carefully weigh the risk of the extraction procedure to the tricuspid regurgitation remaining. TR can be somewhat really well tolerated, and some of these patients have, you know, fairly high numbers of leads and you know, very chronic leads and very high risk with extraction. And so it's an individualized decision. A lot of these patients now are getting evaluated for tricuspid valve procedures. And, you know, if there is going to be, if we don't extract the lead and the tricuspid valve remains bad, if the consequence is that they're going to then put they're going to jail the lead with a new valve there, that makes me a little bit more interested in extracting. But again, that's an individualized decision based on the risk of the extraction procedure for that particular patient.
Just anecdotally, the first time I took a lead out because of TR, yeah, when you extract the lead, you just pull or delays or whatever. So I made it flail. I made the tricuspid valve flail. I made it worse.
No, when we spoke about this at, you know, a meeting of extractors around the country a few years back, everyone was basically saying that this does happen. It's not exceedingly common, but it does happen. It's very hard to predict when that's going to happen, and when it happens, it very often requires you know, a very experienced tricuspid surgeon to fix this. And we'd love to have better clarity on predicting who is that going to happen to. I have ideas of using ice during the extraction to try to you know, maybe decide to abort the procedure if I think that's going to happen. I think Dr. Corti,
Yeah.
and then Dr.
Thank you
Boyle.
for your presentation. I have a question, surgical questions. So, case scenario, a patient with a bioprosthetic aortic valve with endocarditis, and the patient has a pacemaker. Would you recommend to remove the pacemaker at the same time, even without evidence of vegetations on the lead?
I think that in general, this question has been asked very often, and the majority of us feel that yes, the answer is yes, because if the plan is to replace that aortic valve with a new tissue valve, the consequence of reseeding that new valve, reinfecting it because you never extracted the pacemakers, that's a very consequential outcome. And so if the risk of removing the leads is not prohibitive, I think we should. And if in the operating room, those leads could be extracted more safely, I would totally support that. I think in the majority of these cases, it also depends a little bit on the bacteria. If it's a staph species and you have almost even one culture that's positive, the odds that that is lead endocarditis are exceedingly high. If it is some atypical bacteria like a gram-negative on a valve, which is again rare, there's a little bit less. There is a little bit lower chance that the leads are seeded, but would I want to explain why I didn't remove those leads when the new valve gets infected? No, that would be still problematic.
So Amish, great, I'm sorry.
Final part. Yeah. So, and in that case, you recommend an epicardial implantation at the same time, or wait and do an endocardial implantation later?
Yeah, that's a very good question. Obviously, we love in those patients who are at high risk for recurrent transvenous infection. I think an epicardial approach is totally appropriate, totally reasonable. There are some consequences, though, to epicardial leads. Epicardial leads are not MRI compatible. And due to the work that has to be done to make them MRI compatible and the limited numbers of epicardial leads that are put in nowadays, I'm not sure there is any imminent risk that they will become MRI compatible. Also, the failure rates of epicardial leads is really fairly high. So for younger patients, we really worry about the lifespan of the epicardial leads. So if you have a pediatric or 20, 30, even a 40-year-old patient, that patient who gets an epicardial pacemaker at that time may well require a transvenous lead placement a decade or two later, or 3 later, which is fine. Honestly, it's especially nice if that epicardial pacemaker is put in the pectoral area instead of in the abdomen, so it just makes it easier 10, 20 years in the future to add a transvenous lead. After 10 years or 20 years of not having recurrent endocarditis, that should be very acceptable to everyone. In the modern era, we have leadless pacemaker options, and this also becomes fairly attractive. They're, in theory and in practice, probably removable. So even if you have a young patient in their 20s and 30s, if we put a leadless pacemaker, in theory, when the pacemaker battery runs out, at least especially with the Abbott system, it can be extracted and removed and a new one replaced when you have to change the battery. So there are some alternatives, but if they need a biventricular system, we can't do that with leadless pacing. I think a surgical pacemaker is great for those patients. And in general, I really think most of the time, I think that's the right decision.
Amish, great overview. Couple of questions and a comment. Perhaps the comment first. We see, obviously, we've talked over the phone about, these patients with TR. And so, just for the, fellows and other people, electrophysiology, has become part of the multidisciplinary screening for transcatheter treatment of TR. For example, in the TTVR trial that we have, the Medtronic Intrepid trial, and EP is part of the decision-making to go over these complex issues regarding lead management, lead extraction, figuring out what is the best way to deal with the situation. Is trapping safe thing to do? If, is it not safe to do? Should we remove the lead? Are they lead dependent? So there are all these nuances around these issues. So, we are, obviously, this is a new frontier, new arena. So we are learning, and we really appreciate our EP colleagues' input in this. Two questions I have. One is with regards to the aspiration of the vegetations. Do we have any experience, sucking out these vegetations from the left side? Sometimes, we are called upon to see, patients with large mitral vegetations. They're not really surgical candidates. What experience do you have, if any? And the second is, when you're implanting leads, we see a lot of patients with, TR and leads. It's hard to sometimes figure out, as Miguel said, whether the lead really is the cause or it's just an innocent bystander. Be that as it may, when you implant these leads, are there techniques or different ways that you have, learned, or, are there different ways to implant these leads or use intracardiac echo or imaging to minimize the risk of interaction of the leads with the leaflets down the line?
Those are great questions. So really, they get at the heart of the future of putting in leads. The first question was, remind me, the first question was, oh yeah. So the angiovac is something that has been used for left-sided vegetations. It's also been used to aspirate clots in the left atrial appendage. It is definitely usable that way. I have sort of stayed in my lane. We're using this for lead vegetations, and so lead vegetations are generally right-sided. So I have not personally done this in the left circulation. I do support the idea of doing it. I would love to do it for the right patient. I think it's very feasible in general. I know many people have done it. I've talked to them. It seems to be very straightforward. Obviously, there are some additional precautions that have to be taken. These are patients who should get sentinel devices or cerebral embolic protection devices during the procedure. But I think many of the same patients are relatively high risk for surgery, and definitely this has very much worked for these patients. There's no study. There's limited. Basically, the literature is case reports. But I definitely think we have enough experience with the system on the right side that it is very much doable on the left. For the second question, using echo in the initial implant of a right ventricular lead is exactly what I do if I have to put a lead through a recently repaired or replaced tricuspid valve. So we put intracardiac echo. I can do that from the pocket, and I can confirm immediately during the procedure that my lead is not impacting the recently with hard work placed tricuspid leaflets. So it is very much doable. Is it something that should be done for everyone? Anytime you're putting a lead through the valve? Probably not. Are there techniques, though, for putting a lead in that won't have the risk of impacting the leaflets? Yeah, leadless pacemakers should, in general, be safer, although there is some risk. I like to, when I enter the tricuspid valve, when I'm trying to put in a lead, I like to see the wire prolapse so that sort of there's a U shape of the wire going through the valve. That lets me know that I'm very unlikely to be going in between chordae and or through the leaflets. That's that's when we're putting in a physiologic pacing lead, which is our standard of care. There is a risk when we put in physiologic pacing leads also of damaging the valves, but I think it's actually less. That really needs to be addressed with data. But certainly if you put it in for left bundle leads, you have less risk because it's a little bit more apical than what we were doing for his bundle pacing. But there are techniques during the procedure to try to help address this risk. And most explanters, extractors who have experienced problems with the tricuspid valve from leads really pay close attention to that. Whether we're successful or not at damaging the valve really requires an analysis of the modern generation of leads. In the modern era, in the last 5 years, really very few people should be getting the same kind of right ventricular pacemaker leads as we were using 10 years ago. Everyone really should be getting left bundle branch pacing leads instead of a right ventricular lead. And so whether that is inherently better or safer, and whether the techniques for putting it in can be tuned for that is something in development. But definitely I'm very conscious of that. We try.
How and why does renal failure contribute to lead complication?
Yes, so we can very readily tell when a patient has had CKD when we're trying to extract, because the binding of these leads to each other and to the tissue is so strong that the laser fails to advance in many of these patients. So when a patient's been on dialysis and they have to go through extraction, the laser it's like hitting a rock. You can feel it, you know, it really, it gets so calcified from their renal failure. And, you know, sometimes we wind up having to switch from the laser to mechanical cutting tools to try to get through the calcium in this. So I think that's the main contribution. Ryan.
Have any data on using the angiovac or alphavac on the thrombectomy of the right atrium or SVC thrombectomy?
I have, when we put the angiovac in to remove vegetations, you know, when we think about vegetations, we immediately start thinking of, on leads, we're thinking of the tricuspid valve area inside the right ventricle or inside the right atrium. But the thing is, there's no inherent reason for the bacteria not to be in the subclavian vein, in the innominate vein, in the high in the SVC, where a TE probe won't readily look. So when we push the angiovac catheter up into the SVC, up into the innominate vein, et cetera, we get more vegetations out. So, you know, could it be used for thrombectomy? If there's a discrete, not very, very, very hard, not very adherent to the wall thrombus, something relatively mobile, it could be used in those areas in the SVC or in the right atrium. It won't work well, I think, if the mass that we're trying to remove is very adherent to the wall or is layered or things like that. Then it won't work. If it's endothelialized already, if it's very chronic, it probably won't work. But if it's mobile, we can remove it.
Great, I have a consult for you then.
Okay. All right, well, thank you.